the OR and the ICU. I guess it is not as in simulation what happened on Vegas, stay on Vegas, and ICU probably the situation is so different. Dr. Hussam, we're going to speak about this important topic, which is around a lot of safety like measure, as well as a major issue of the happening as risk management, and related incident is related mostly to communication. Dr. Hussam, he is a pediatric medical as well as pediatric cardiac intensivist and pulmonologist at King Faisal Specialist Hospital and Research Center, Jeddah. Dr. Hussam, the floor of you, and you can start.
الله يعطيك العافية دكتور حربي على الانترودكشن والefforts. I know إنه حاصلة بين الشوطين في كأس العالم, so we'll try to wrap things up efficiently, and then inshallah إنه we'll achieve the goal from this talk. طبعا why did I choose this topic, or why do I focus on these things? And these are the areas of improvements that can be done easily, inshallah. With some collaboration with our colleagues from other specialties, and with the good results, whether it's from patient safety, timing, satisfaction, all of that. But inshallah, today we'll be talking about the transition process from the OR to ICU. I know most of us here are coming from an ICU background, as per the survey that I had, and I'm going to share the results with everyone in a few minutes. I'm going to talk a little bit about what is a team, the importance of handoff process, and moving forward. Now, knowing this knowledge, what can we do, or how can we move forward, and how to implement such processes in our units. So what's a team? Basically, it's any set of two or more people who interact dynamically, interdependently, and adaptively towards a common goal or mission. Of course, they both have assigned or specific roles to perform to achieve this specific goal. For example, when we have the relay baton race in the Olympics, it's going so fast. It happens between different racers in series. Someone needs to run so fast. The other one should be ready, opening their hands to receive this baton or this stick that you see in this image. Imagine if the one who's coming didn't have it in his hand, or did not coordinate well with his teammate. What would happen? The entire race will just be called off, and they will just lose everything. What about the other teammate? What if he wasn't ready at all? He wasn't opening his hands. He did not get set or ready to start moving forward. The entire process will just fall apart. So each and every step should be measured appropriately. Should happen efficiently, quickly, and in a very quick manner, very safe manner, so they can win the whole thing, or they can keep things going. So exactly what happens in the ICUs, we get the patients from the OR room. When we get the patients from the operation room, a lot of transitional processes happen there, includes the transfer of patient information, equipment, responsibility, and accountability from the OR to the ICU team completely transfers or moves with the patient. So the communication of surgical and anesthetic considerations from the OR team to multidisciplinary ICU and nursing team is vital in enhancing patient safety. It cannot happen in a random manner. It cannot happen in just a haphazard form or a transition of care manner. There has to be a structure to ensure that every information and each step that happened in the OR been transmitted to the ICU team, because this definitely will affect the management of the patient down the road. So what do we see here? The top line is the OR team. The bottom line is the ICU team. We have the patient coming from the OR, supposedly accompanied by a surgeon, anesthetist, a nurse, a respiratory therapist, and a perfusionist in cases where patient is on ECMO or having like a very complicated surgery and they could not take the patient off the pump, especially in cardiac cases. On the other hand, the recipient team or the ICU team concludes of intensivists. Of course, it's not one intensivist. There will be like a fellow resident sometimes, assistants or registrars in some hospitals, an ICU nurse, ICU respiratory therapist, and perfusionist. And of course, in the middle, we have the patient who's connected to a ventilator and the monitor. So imagine the responsibility of getting that patient from the OR to the ICU in critical condition should happen between a team of 9. How is this happening nowadays? I want everyone just to imagine what are the processes that are going right now at their units. So, but from what I gathered, or from what we've been seeing or hearing, that we know that if there is no structure, what will happen is the surgeon will come, they will just pull the intensivist and give them some information. Dr. So-and-so, this is what happened in the OR, everything is okay. For example, we had some bleeding, etc. And they just step aside and leave. After that, the anesthetist, they can do it at the same time, and they both talk to the intensivist separately, and you can see that there is no communication with the rest team members. The OR nurse, whether she called the nurse by phone before coming to the ICU or after accompanying the patient, she would just talk silently or whispering to the ICU nurse about what happened. And the nurse here at the same time, she will be busy managing the patient, moving his lines from the pumps to the ICU pumps, fixing the monitor, getting things together. If the patient was sick, they have to stabilize the patient. And all of this is happening at the same time. And then the RT, the transport RT, if there was one, will talk to the ICU respiratory therapist, talking about challenges in the vent, the tube, the placement of the tube, where is it exactly, and whatsoever. And the perfusionist, of course, will talk to the perfusionist. In the unit, we can see here that this is happening in parallel fashion. No one is sharing information with the entire team. The information the intensivist has is lacking from the nursing or the RT standpoint. And you think that that's it, and this is where it stops. I think we wish, but again, the anesthetist wants the nurse to be sure that please be careful, this patient has a difficult airway. Please make sure that the ET tube doesn't go deeper than X, Y, and Z. We noticed that this patient had some hemodynamic instability. This patient loves this mean arterial pressure. Also, the anesthetist will talk to the RT to give the same information as well. At the same time, the RT from the OR or the transport RT, if there was one, will reach out to the nurse and the intensivist with any concerns that they have. And the same thing, the perfusionist from the OR will come talk to us, intensivists, the nurses and RTs, about the gases that they've been having on the pump, about the pressure that has been ongoing on the ECMO itself, and whatsoever. So we went out from parallel to just a spider web. Everything is just going all over the place. There is no common ground. I mean, everyone is confused here. You see the intensivist is receiving messages from everyone. The nurse is getting a message from everyone. And at the same time now, this team, the ICU team, might have questions, might have to ask, so where are we here from this process? So the whole picture here has to be well organized, and it has to be kind of standardized just to have a very good practice and safe practice, let's say. So if you look at this picture, I want everyone to imagine how many chains of communication is happening. I think in here it's around 12 or so. But as we know that the number of communication channels between a group of people, it equals a square of those number of people. The more the channels, the more channels of communication, the more chance to losing or omitting important information. But imagine we have like a nine people in there. Okay, if you put it in this equation, you will get 20 something, and you have a huge chance of losing important and critical information from being transferred from the OR to the ICU. So what's at stake here? Of course, first and foremost, we have the patient. The patient should be our priority. We have to focus on the patient's safety and the transition of care. So losing or omitting critical information or information omission will definitely lead to mortality and morbidity. If you don't know that this patient likes a map of X, and you just think that, oh, he has a normal map, when his RV is sick and he needs to be on a higher map and continuously, not as a boluses, that will definitely lead to some areas of morbidity and mortality in there. A lot of studies have been done about that. and there is a lot of data out there that I'm going to share with everyone here. It is important. Important post-operative information loss happened after 52% of handoffs, with only 30% of essential surgical information being transferred. Imagine in a study that happened in 2002 by Anwari and his team, they were studying how much information that came out from the OR that was transmitted to the ICU. 30% of the essential surgical information has been transferred. So imagine that the team do not know about 70% about what happened in the OR. Another paper discussed sentinel events and its attribute and how it's attributed to communication error, and found that 85% of sentinel events, with up to 43% of those happens during handoffs. So half of sentinel events basically happens because something went wrong during handoffs. So that just tells us what's at stake there. Of course, in addition to the patient, we have our teams, they need to feel safe, they need to feel involved. Satisfaction is important. Feeling of stability and standardization is also important as well. In another paper that was published in 2007, a review of around 450 surgical malpractice cases revealed that 13.5% involved communication breakdown, which happened in an evenly distribution manner in between the perioperative, preoperative, and intraoperative. In addition, another paper looked into root cause analysis and see what happens because of ICU or OR ICU handoffs, and most of the near misses happen during the handoff process. So if you fix that, you will fix a lot of near misses there and prevent further complications to our patients. When I was preparing for this talk initially, when I was getting this topic together for myself and our team, I looked at the literature. I did a prolonged search on what's available out there. But luckily, I found that in 2009, there is this very important article. It's the handoff from operating room to the intensive care unit after cardiothoracic surgeries. It's from the Society of the Thoracic Surgeons Workforce on Critical Care. So basically, they did a systemic review about all the papers out there, and they discussed it with all the references. The parameters that they collected in this review article included 21 studies, 14 were from North America, and 7 were from centers in Europe or South Africa. The mean number of patients included in the studies was 304 patients, ranging between 25, and some papers just had number of patients that exceeded 1,500. They looked into handoff completeness, prevention of adverse events, and the effect of handoff standardization and and measures compliance and provider satisfaction as well. When it comes to handoff completeness, 18 out of those 21 studies looked at that issue. It was noted that both technical errors and information omission significantly reduced with the standard fashion of handoff process. Critical details were communicated significantly more. And in a paper from 2016 that was published in the Journal of Anesthesia, it showed that personnel attendance increased from 20% to 87%. So the people we just saw in the diagram I showed everyone, the attendance increased. We know some surgeons or anesthetists or ICU personnel, they prefer just to get the information and leave. They noted that with a standardized handoff, you have increased attendance of teams, parallel conversations reduced from 100%. Imagine everyone who did not have a protocol or a standardized fashion of transformation of care had parallel conversation. Everyone, so it was 100%, went all the way down to 60%. The mean number of interruptions during sign out decreased during the anesthesiologist and surgeon handoff as well. Of course, this is what we mostly care about, prevention of adverse events, that was looked at in 6 projects actually. And there was one of the biggest ones included in the systemic review or the review article. A group of 1,078 pediatric cardiothoracic surgery patients with a standardized post-operative handover was associated with decreased incidence of resuscitation, meaning worsening of shock and having cardiac arrest by 3%, mediastinal re-exploration rate also dropped by almost 4%. I mean, it's half the number almost. And metabolic acidosis, I mean, when you look into it in a patient with a cardiac, the cardiac ICU, metabolic acidosis is a representative of a lot of post-cardiac, low cardiac output and other shock state. Also reduced from 6.7% to 2.6%. In addition, it was noted that early extubation rate went higher, which is great. We want to extubate the patient earlier. So the rate went up by 7% from 43 to 50%. They also looked into measures compliance. Of course, who would be better than a Formula One team? So imagine in Formula One, there is something called a pit lane. A pit lane is the lane where the car just moves aside, steps aside, stops, get the tire changed. There are 21 people involved in this process. Imagine just to change 4 tires, they have 21 personnel involved in this process. Each person has one job to do. They do it in around 2 to 3 seconds. So they are waiting for the car to come. They are ready for the car to come. And when the car comes, each person has his own job or task to do, right? It sounds familiar, right? We have to wait for the patient comes, each one has their own task to do. The same thing. So who's going to be better than those people from measuring compliance, right? So actually they involved them in the study. They looked into the ICUs there. They looked into equipment and technology handover, information transfer, duration of handover, and teamwork. They noted that the mean number of technical errors decreased from 5.4 to 3.2% per handover after implementation of standardized protocols. Also, omission of key information went down as well. And the paper is here. You can look it up and look at the results. But it's a little bit old. It's from 2007. One of the parameters that are looked at as well is provider satisfaction. Looked at in 13 out of the 21 studies. Everyone, of course, were happier with a standardized process, especially if there is a reduction in handoff time, more quiet environment, and the factor that led to dissatisfaction, basically that the team felt involved. The nurses felt that they know what the surgeons did in the ICU. They know what the anesthetists want. And of course, the consistency of the process. So not each patient comes, they have to look for the intensivist, where is the surgeon, where, everything was set, everything was written down, and they had it standardized. So satisfaction is achieved this way. And actually, it's a great thing it's not an easy thing to please everyone, but if you achieve satisfaction amongst your team, I think we're doing something good. So basically what we want to do, or what people are trying to do or trying to achieve by standardizing the transition of care, they want to get this into that. So basically you want one channel of communication. You want the surgeon to speak to the entire ICU team. You want the anesthetist to talk to the entire ICU team. If there is any concern by a nurse, RT, or perfusionist, to be addressed to the entire team members. What is the benefit here? We all have the same information. If I forget something, my nurse colleague will remind me. If something that needs to be addressed upon, because we have a lot of shift changes and also a lot of things. We have many patients, so it's good to share the same information by the same source, so we have things running together. Of course, when you do that, there will be no parallel discussion, omission of information. There is only one line there. It's one information. You have to hear what's happening there. And of course, this side of the equation or of the handoff process, they have to have like a structured pattern to go over. It's the surgeon will come. I'm going to go over a few examples in a few seconds. The surgeon will come. We'll discuss what surgery happened, what type of surgery, the anatomy pre and post, what to expect. Anesthesia will, for example, discuss airway maps, etc. And the nurse will discuss, lines, and they are all happening in one fashion. One line, one chain of communication, one team receiving this information. Time is less. It's a quieter process. Believe me, I've tried this. Everyone is happier afterwards. So now we need to think about what we can do or implement, right? We have to first understand our current process and identify areas of improvement. Then we have to develop and simulate and implement a process that works for everyone. It doesn't matter. It doesn't mean that what I'm going to show you right now might work at your hospital, or what's in the literature might work at my institution, for example. And then after you implement whatever process you decide to do, the evaluation of the process needs to happen through observations, chart review, and interviews. Just talk to the team members and the involved stakeholders and see what's happening and how you get things moving forward and better. I'm going to share with you the results of the survey that I sent prior to this presentation. Around 35 correspondents were there. I understand that it does not mean 35 units because more than one person might represent the same unit. Most of the participants were from general pediatric ICUs. Some are from purely pediatric cardiac ICUs, and then the last group was from mixed unit. Around 99 or 98%, 34 out of the 35 work in a unit where they receive patients from the operating room. So standardization of care, actually, when it happens, it doesn't mean that we need to do it in the cardiac ICU per se. I mean, it's a process that you can move it amongst all units where patient is moving from an OR to ICU, OR to the floor. I mean, even between transferring patients between floors, having a standard of care will improve everything. So even if you do not, if you work in a mixed unit, you can do that. In a pediatric ICU where you get patients from neurosurgery, pediatric surgery, orthopedics, you can also do that. But the stakeholders will be more. People that need to educate will be more. Around 68 or 66% of the responders mentioned that they do not have a transition of care or handoff protocol. Actually, having around 34, it was impressive to me. I thought the yes response for this question will be less than that. So that's actually a good thing. At the same time, and what I find it interesting that when asking about satisfaction, it's a close result here. 55 said yes, no, they were not satisfied, and 45 said yes, they're satisfied. But almost everyone thinks that they need to standardize the care. So it's so happiness or satisfaction here does not represent the question on the right side. So apparently there is a lot of room to improve, a lot of chance for all of us to work at our units and work together collaboratively. So where do we start? First of all, you have to have a goal, okay? Let's say that you need to have a standardized process that is reproducible, that can happen whether you are on service or someone else is on service. It has to be safe and efficient. Have it structured, have the surgeon report, then the anesthesia talk and say their part, and then us as intensivists, we accept the care and summarize the plan. I'm going to repeat this information several times and then the next few slides because they're really important and critical if you want to work on something like that. If there is a clinically important information, it needs to be included as part of the sign out. Ideally, there should not be side conversations. The room should be quiet so everyone can listen. And the message will be delivered once at a time to the entire team. So one message to the whole team. You don't talk to me or my colleague individually. Talk to us as one team so we can all hear the information together. So the patient pre-transport, ideally, there should be a nurse-to-nurse call. The ICU room should be ready for the patient to come in. So the OR has to notify the ICU within, I've worked in places where we have a 1 hour notification, half an hour, and even when the patient is on their way, notifications. So the team should be ready. Remember the Formula 1? The team should be ready. The bed should be ready. Resuscitation medications are ready. Pumps are ready to be transferred. Then the physical transfer from the OR to ICU will involve transportation of the patient, technology transport, like the monitors, lines, pumps, infusions, drains, other technologies like ECMO or ECLS support, etc. Then the formal transformation or transfer of information happens, whether you start with surgery or anesthesia. You can work this with your teams, and then the ICU will summarize the plan and request the labs, ECG, look at the patient, etc. So as a summary, the surgeon will come and talk about the physiology and what happened, and we will review the chat. What we need to do is we need to understand the current physiology of the patient, the previous physiology, what to anticipate and challenges that are anticipated, and a specific condition complication for a specific condition. For example, if it's where I work, we do a lot of single ventricle procedures. So their complication, the anticipated complications or things to look at might be different than, if we're getting a patient with ASD or VSD. So we have to be specific and work patient by patient. We have to just individualize care here. Establish early goal of management. It depends on your complexity of the care. What do you want after 6 hours? When do you expect, for example, low cardiac output syndrome? If a patient in the ICU, for example, with a spinal injury or spinal surgery, this is what you expect. His sympathetic pathway, for example, might not respond to X, Y, and Z. You have to put goals because you're not there, and everyone needs to be on the same path here. Pain and sedation plan. And when do you expect to extubate this patient? Because when you talk about that, you will also affect number 3 here, the pain and sedation. Do you want it to be intermittent? Do you want it to be continuous? And etc. So when we have a goal-directed plan, it goes by system. So after the surgeon talks, the anesthesiologists speak, I'm going to discuss what are they going to sign out to us. Then we receive the information and set a goal by system. Or at least this is you can work whatever system works for you. But I think having a specific goal by system, like when you talk about cardiovascular, you have a specific blood pressure goal. This is the intensivist talking to the ICU team who will be handling this patient. What is the filling pressure goal? You need to worry when this CVP goes below X. The rhythm, does this patient need to be paced or not? What mode of pacemaker? What temperature this patient needs to be on? Is he someone with a head injury, or you want to do some low thermic or hypothermic protocol for this patient? When do we start diuretics? When do we do all of these? So this all goes under CV, for example. Pulmonary, you talk about FiO2, your vent settings, get your chest X-ray, do the labs, blood gas schedule, when do you space it? And then you talk about sedation, hematology, you talk about your hemoglobin or hematocrit, anticoagulation and hemostasis plan, and nutrition, whether one you want to feed the patient. And when you talk about the idea in a specific antibiotic per your hospital policy and protocol. So the key here is to have a good bedside assessment, good communication with the team. There are things that we need to explain. This slide is mainly for the cardiac ICU attendees here. What is the dominant physiology of this patient? Is it an RV dysfunction? Is it LV? Are we expecting a low cardiac output syndrome here? Does this patient have a wet lung? Is it a non-compliant lung? Do we need to diurese? What pressures do we expect on the ventilator? Does this patient have limited pulmonary blood flow? Is it too much pulmonary blood flow? What do we expect on the ventilator? Do we need to rest that patient? Do we need to paralyze that patient? But whatever you do, there are things that you cannot miss. Bleeding, effusion, tamponade, these are big red flags there. Hemodynamically important rhythms. If this patient is in jet, complete heart block, this patient needs to be paced. As mentioned as well, low cardiac output syndrome. And if they're in permanent hypertensive crises, if the patient is at risk of that. And one of the slides, I'm going to discuss this as well. And then discuss how can we move forward with this care and what are your goals within the next. Actually, I usually put 1, 2, first 6 hours, I do it hourly, and then I start pacing things, especially if the case is complicated. I have an example here just to make things easier. Let's say there is a 3 months old immediately post-op from a valve sparing tetralogy flow repair with a small residual VSD by echo. This is what the surgeon is giving us. Okay, the patient also has a PFO, favorable dynamics, no issues with hemodynamics, good RV function based on low CVP, which is okay. The patient has left to right shunt at the level of the PFO, good blood pressure, low lactate, on very mild vasoactive medications. What do we anticipate? What do you anticipate as an intensivist? They will talk to you about anticipating some RV dysfunction following the repair because this patient had a very long bypass time. So you keep in mind some of that complications, risk of arrhythmias like jet. If hemodynamics allow, we might plan to extubate this patient in the morning. And then you go system by system, as mentioned in the previous slide. I know it sounds like a lot, but when you do it on a daily basis, believe me, the whole process will not take more than 4 or 5 minutes if everything is going well. You set the goal of maps, rhythm, what do we need to get an EKG or ECG, you do these blood labs, X-ray, what do you want to do from lung standpoint, neuro, as mentioned, and you set exactly what you want to do. As for the surgeon and the anesthetist, if you want to work with something like that, the Society of Thoracic Surgeon Workforce on Critical Care, the same paper I just referenced, they provide an example of what do surgeons and anesthetists will go over. For example, the surgeon will talk about the surgical procedure, the indication for the surgery, any surgical issues that they found during the repair, issues with separation coming off the pump or bypass, did they use the fibrillation or not, bypass time, cross clamp time, circ arrest time, but I mean, those sometimes you can get it from the perfusionist or anesthetist. So this is just an example. Bleeding issues, how much chest drainage happened in the OR, packing and wires, lines, what happened with the family, is everything was discussed with the family, any other issues that are relevant to the ICU care, do I need to know more information from you, any echo was done, what concerns do I look for in this patient? And then comes the anesthetist. They will discuss mainly the lines, IVs, central lines, what this patient, the intubation process, was it an easy intubation, a difficult airway, tube size, location, depth, etc. They will also discuss the vasoactive medication that the patient is on, inotropes, vasopressors, antibiotics, what time they were given. And of course, since they are at the monitor side there, they will discuss the favorable hemodynamics and where the patient likes the map to be. How many volume did this patient receive? Were crystalloids, RBCs, FFPs, etc. And then the desired hemodynamics as mentioned. Last gas, last hemoglobin, last lactate. And after all of these processes are done, our role will come and discuss what I just mentioned to everyone with the example. So in an ideal world, what will happen, the ICU team will be waiting for the patient. The receiving nurse will only listen and takes note. You will have another nurse helping that nurse with her patient. طبعا ideally before all of that, there will be a phone call, 30 to 45 minutes, and there is an on-the-way call. When the patient comes to the ICU, before anyone talks, the transfer monitor should be transferred to the ICU monitor. The lines should be transferred, or this can happen by a separate nurse. This is so helpful because you can get the sign out and look at your patient's monitor. Of course, we're talking about a patient who is not actively being resuscitated here. The report will start when the vital signs show on the ICU monitor. Nobody talks before then. I think this is very critical and very ideal. A staff and anesthesiologist responsible for managing the sedation and hemodynamic during this time. No interruption of handoff with questions or talking. It can happen afterward. Then the surgeon will talk about their checklist. Anesthesia will go over afterwards, and then us will discuss the team and will answer any questions by the nurses. The HATRIC, it's like a PI project or a quality improvement project that's happening at Penn State, University of Pennsylvania. They have almost the similar, I just put it here as a reference so you guys can look it up if you want to. Introduction of providers, it's almost the same thing. Stabilization of the patient, you transfer the monitors, there will be a huddle, so on, so you're also introduction of everyone. Surgeon will talk, anesthetist will talk, then the ICU, and there will be a short physical exam and exchange contacts, and then if there is any questions. So in conclusion, handoff in critical care plays a huge role in the continuation of care, quality of care, and reduction of risks and error. It's also helpful in protection of avoidable harms, improve team satisfaction, and down the road, if you improve all of that, you will reduce cost. Implementation requires multidisciplinary collaborations and teamwork. I personally believe that there is a huge room here for quality improvement projects, research projects, and collaborations between units in different regions in our country, honestly. So, for example, we are doing something now to start this. And as, for example, we'll start it in one unit, cardiac ICU. You have one team to one team. Then you can move it to the pediatric ICU, where we have the more than one service delivering patients to us. After that, if they like it, adults can take it, and it can just grow with you, you know. I think it's a great project, definitely room for improvement, and you will definitely have great results for the patient and for your team. That being said, أتمنى إني ما أكون طولت عليكم. الظاهر ما أدري إذا المباراة خلصت ولا لا. تقدروا تلحقوا عليها. But as you can see, if anything goes wrong here, you will not make it till the end. الله يعطيكم العافية. I'm open for questions.
Amazing. Dr. Hussam, thank you so much. It
الله
is
يعطيك العافية.
very informative, very much needed talk. And speaking about safety, I feel that's one of the major safety. And it's not only you describe the problem, you put the solution, and also you look for further improvement on our region. Thank you so much. It's amazing. I really enjoy it from the start to the end.
Thank you for having me.
And we have the time for the participant to raise their hand and to start question. And also I have some question for you, Dr. Hassan.
Sure. I see that Dr. Yasser Kazzaz.
Okay. Dr. Yasser, probably you could unmute yourself and you can start the question.
السلام عليكم يعطيكم العافية وشكرا دكتور حسام.
السلام عليكم دكتور ياسر.
For arranging this much needed talk. I have a question regarding the team satisfaction. Is it only the receiving team or actually even the team who gives the endorsements like surgery, anesthesia, and OR nurses?
So that's a tricky question, صح? I know the anesthetists and surgeons want to drop the patient, give you the information and leave. I think it's mainly nurses, intensivists, of course, and the people who are receiving the patient. Basically it's the receiving team. You might actually add burden to the OR team for them to just stay longer. But I think if we look at the patient down the road, everyone will be happier that their surgery went well and less complications happen for their patients. But the dissatisfaction here mainly happened, or it was people who are involved with the ICU team.
Thank you so much, Dr. Yasser. I think we have also Dr. Ayman. You can unmute yourself, Dr. Ayman.
Assalamu alaikum jami'an. Thank you, Dr. Hussam, for this wonderful presentation. If you allow me to share my thoughts regarding the handover, what about retrieving the patient rather than receiving the patient? I mean, if the ICU team with the whole team receive the patient who are in OR, I think this will give you a better picture what's going on just before the transfer, and I think this will be more informative.
Okay, this is an excellent point that you raised. I think that there are units who actually do that. For me, I prefer getting the patient in the ICU. It's my comfort zone, and for me is having. I'm talking personally. Some units, I mean, majority do not do that, but I've seen units where they physically go to the OR and receive the patient there and then move the patient and move them to the bed. To me, as an intensivist, and I'm talking personal preference, having the patient coming to my area, having the patient connected to his final destination in the ICU, after getting everything set, I mean, this is what I feel I would do, honestly speaking. But receiving the patient in the OR exists, and I know some hospitals are doing it, and they're actually happy with it. So you can do whatever works for your hospital, but I think it should be standardized fashion. But that's an important point. But most of the studies I saw there was actually one paper I read about going to the OR, and they discussed that question there, but they did not differ between receiving the patient in the OR or the ICU, but they also have a standard care through that.
Thank you, Doctor.
Of course.
Appreciate Dr. Ayman, and we have Dr. Abdullah Tayyib.
Assalamu alaikum.
Assalamu alaikum, Dr. Abdullah.
Dr. Hussam, Dr. Ali, very excellent presentation, Dr. Hussam. I enjoyed it, although the match is there, but you attract us to watch this very nice presentation till the end. I like the foot of the Formula One teams. It represents all this presentation you have presented. My question is that you share the checklist, which is from the cardiothoracic paper checklist. Do you go through any standardized ICU, general ICU or cardiac ICU handoff, standardized checklist sheet for handoff?
You mean at our hospital?
No, I mean general from the ICU consortium or generalized
Yeah.
ICU checklist for handoff receiving.
Yeah, and I looked into this, and this is the standard one. I found it for the cardiac surgical ICU. I've been at places where they have checklists, بس مع الوقت تصير محفوظة عرفت؟ خلاص.
Yeah.
We want to know X, Y, and Z, بس ما في شيء يقول لك there is nothing that it tells you need to do this, start with this, start with that, as long as you're covering the pivot or as long as you're covering the vital information about the patient. Do it the way you want. It's not even a guideline. حتى guideline you don't need to follow. It's just like a simplification type of thing. Do it the way you want. Just do it, you know. Examples are out there. They're different. حتى الهاتريك خليني اوريك السلايد ما ادري اذا خلص. شايف هذه عملوا they did their own هنا.
Yeah, this is for Pennsylvania.
You know, yeah, they did their own, but and they have it on their website. If you go into the Hattrick website for this project, they have their own thing there. So you can come up with whatever you want as long as critical information. And it's a dynamic process. If you don't think it's working now, you can always change it. If you think that an information that needs to be there, ممكن حتى هذا اللي على الويب سايت doesn't work for you. You know, it's different. It depends on the setup that you have.
Yeah, clear. Thank you so much, Dr. Hassan. Thank you.
Allah يعافيك.
Appreciate Dr. Abdullah, and also we have Dr. Adib.
Adib.
You can unmute yourself, Dr. Adib.
السلام عليكم ورحمة الله وبركاته.
عليكم السلام يا هلا.
Good evening. شكرا Dr. Hassam. You are always amazing in your talks. And thank you for the organized committee. First of all, I have just a minor comment for Dr. Iman. Hopefully our colleague from anesthesia and the surgeon, they will not hear her comment about going to OR to receive them, because we're going to struggle out with our shortage of number as intensivists. I guess what I want to mention in few seconds, that I do agree that it is a dynamic process. Every unit should find their own way of handover receiving the patients in very comprehensive way to know in detail what's going on. I believe the process will start from pre-op planning or pre-CAT planning, sitting together, reviewing together, deciding together, and then having the complication on the OR on the table. I just have minor question, Dr. Hassam, and without a specification for any hospital or an institute or any place in the world in general, there is always an agenda in the OR in the cath. You will not find it except in midnight when you call the surgeon or the cardiologist. What do you think the best way to overcome these problems?
Okay, this is an excellent point. I think I was discussing this question with Dr. Ali prior to this talk. So I think the way to do it is to involve all the stakeholders. You have to get cardiology on board, you have to get cardiac surgery on board, and anesthesia on board. Get the head of each department, and it's a must. You know, it has to be a rule. There should not be a way around it. This is our care, this is how we will provide care, and this is how it's going to be done. I think that's the only way that you can get everyone's buy-in. The other thing is, I honestly, I would not mandate that the consultant cardiologist or cardiac surgeon to be there. If the assistant in the surgery was there, that also should do. Whoever was helping with the procedure, doing the procedure, should be there, but someone need to be there. And when you do your project and you have more results and show good response, and it becomes the habit, خلاص, they will have to buy into your process. Just get the buy-in of the stakeholders. And once you have them in your side, I think they can push things with you. Just build a team and you think you should move from there.
يعطيك العافية حسام. شكرا.
الله يعافيك.
I think we have Sophia and also Dr. Saleh Shehri. I think the mic for Sophia is not connected, so they cannot unmute Sophia, but you can start, Dr. Saleh.
And Sophia, if you want to type, you can type and we can read it. Dr. Saleh, تفضل.
السلام عليكم ويعطيكم العافية شباب.
السلام الله يعافيك.
It was very nice talk, really. I enjoyed. Did you find, just trying to see historically, if you want to compare the care of the surgeon, cardiac surgeon, as extended care of post-op in the ICU. And I see some of the old colleagues, I mean, the old school, the cardiac surgeon will continue to pass by in the ICU and they're intervening in the care. You know, this is getting less nowadays, but what do you think? Having some extended intraoperative care in the ICU, which is the old fashion of the cardiac surgery. What do you think? Does that necessarily make big difference in the care, or the things now getting more organized? What I am feeling at a different level of handover post-operative, also being away from the patient, the primary surgeon or the team in the OR, it creates some little bit gap. So what do you feel about this?
In the end, the surgeons are the one who did the surgery, right? And they invested a lot of time and effort in their patients. But I think, as you mentioned, it's an old way of doing things. Now the pediatric cardiac ICU is evolving on its own. And most teams, actually, they run the patients by themselves. But still, the surgeons will have their say and put sometimes, and we go in discussions with the surgeons on what would work better or not. Yes, I've seen some units, actually, they do not have intensivists. It's purely running by a surgeon, but they suffered, you know, because the post-op care will require your assistant surgeon to live in the hospital. You know, I do believe that everyone needs to practice in their own area. I think that having an ICU that's run by cardiac intensivist or anyone who's trained in intensive care, not background of cardiology or background of pediatrics. They have to be specialized in the critical care part of it with training in cardiac surgery or dual fellowships. Whatever exposure you have dedicated to that unit is the safest way to go. But the involvement of cardiac surgery is still important. I mean, they do not have in the end, you want to come with the safest result for your patient. They will have their opinion. When you see someone talking about what antiarrhythmic you want to do, I mean, some people do prefer this patient for this medication for the rate or rhythm, but in the end, it's a discussion. But having a unit run by a surgeon, and I don't think this is, I don't see it nowadays in pediatrics. I've seen it in adults, but pediatrics, it's physically, ما أحس إنها ممكنة, you know, it's not feasible nowadays. For pediatrics, I'm talking.
Much true, and I guess nowadays, like with the starting and increasing the number of the pediatric cardiac intensivists as well as the pediatric intensivist, I guess the presence of the surgeon, which is I feel most of them is already in the background. They already know how to deal on the ICU in general. But I agree with you, like more invasion, more involvement, more advancement on the pediatric ICU is being added nowadays. And totally agree with you, Dr. Hassan.
I don't know if the chat option is open.
Unfortunately, yeah, unfortunately not. I'll try also again, and still, Sophia, probably the like the mic connection is not there. So unfortunately, not able to make you able to unmute you at this stage. So any further question for Dr. Hussam? I would ask Dr. Hussam, especially which as I feel like how important this talk, and I know and probably general ICU or general surgical ICU, probably the risk is much less. But however, it seems to be there is element of the information could be missed, or the area of channel of the communication could be affected during the transfer. Do you think also implementation, which is I feel starting this quality project will be amazing in our area, also implementing this process on pediatric general ICU will be have added value and to minimize the risk of the let us to say near misses or sentinel events?
Yeah, definitely agree with you, Dr. Ali. There is no complication. There is no such a small complication. A complication is, you know, is dangerous, whether it's in the heart, it's in the eye, it's in the brain, or it's in a fractured arm, you know, as long as the team receives the information safely, efficiently, and everyone in the caring team is involved in this and receiving this information, I believe managing care should improve. Because even in the ICU, if you have a patient post, let's say, what's a small surgery, if they just like appendectomy, for example, and the patient is septic, you need to know what happened. You know, things need to happen in a systemic and an organized way. I think حتى مو بس في ICU, even floor to floor transfer. If you get a patient from the OR to the floor, especially to the floor where they don't usually deal with critically ill patients, this should also happen in a standardized way. But again, I will say you have to get the surgeons, you know, and this will happen. You know, I tried it now. So I'm بدأتها like a teaser or a test عندنا في المستشفى, and it's happening. They love it. حتى surgeons, they think it's a good thing to happen. I got the buy-in of the cardiac surgeons يعطيهم العافية عندنا, and the team always is cooperating with this idea. Anesthetists, nurses, actually, the nurses are, if Dr. Yasser was asking about satisfaction, nurses were the happiest people with this process. I mean, I had only an N of 2. I did it twice, but I'll let you what happened. I know what happens down the road. But I think it's important, not only in the ICU, even outside the ICU, anywhere where a patient comes from OR. I mean, حتى لو طالع فين. I mean, I think that there should be a sign out that's proper, a sign out that's clear, and includes everything happens in the ICU. Because I think Dr. Yasser was also referring about, you know, what happens in the OR. You don't, you know, sometimes it stays in the OR, صح? But you know, if I agree with that, Dr. Yasser. But you know, in the end, when you have the information together, things inshallah will work better.
Yeah. Sorry to add also further question, because really the talk is attracted me a lot, Dr. Hassan.
Of course.
Let us to say, especially in cardiac ICU, I would like to say, and I know most of the cases, some of the cases fast track cases.
Yeah.
And with knowing the intensivist probably will be a busy service, as well as you have a lot of administration time, you would advise to keep the senior intensivist who's going to receive the cases and all the time, even with the fast track simple cases?
You mean senior as a consultant, you mean?
Yes.
I mean, if he was there, okay. The most important part here is the person who's gonna put orders, provide care for that patient. I think if it's a complicated case, and a consultant should be there. If it's a fast track, as you mentioned, like a closed ASD or a VSD or someone, we have patients who come extubated from the OR. I think these simple cases, inshallah, I mean, it can go anywhere. By the way, the assistant intensivists are well equipped, knowledge-wise, they are competent, and I think they can run things appropriately. So them being there, they should know when to ask for help or seek for help. This is also important. But you don't need to write down that a consultant needs to be there. The consultant surgeon does not need to be there. The consultant anesthetist do not need to be there, or the intensivist, unless it's really complicated and the patient won't go anywhere without him. I mean, just to make things easier. You don't want to just throw a whole load on everyone.
Definitely true. And last thing I would like to add, we would like to consider this is mandated with wholly protected time for everybody to listen, because I feel channel of the information to be on one time, it will be good, because most of the people, so whether nursing, RT, perfusionist, everybody will be able to listen and focus during this period.
Definitely, that's why you have to have a nurse who should help the bedside nurse. You know, you should have for example, another RT. I mean, if you're short, you're short, okay? But and if the patient is dying, you cannot just leave him die and get sign out, you know? So some situation will control, some events will control the situation. If a helping nurse should come and help, whether it's a charge nurse or a nurse from another bedside next to them, another RT or the charge RT. So the entire team who is going to directly take care of that patient is listening. So I completely agree with you. It should be mandated. It should be protected. That's why when I was answering the one of the questions that I think Dr. Adib was raising, you need to get the buy-in of all the involved stakeholders. When you do that, they will help you and they will make things happen. But I agree with you. It should be protected. Me from me.
definitely.
It should be sacred, like كده مقدسة. هذا الوقت
Exactly.
you
It is
have to receive the patient. Yeah. I mean,
And
because
it is
honestly, getting the information, يعني أحيانا I don't hear information when everyone is talking around. You know, يجيك السيرجن ترى أنا ممكن ما أسمع.
distraction, a lot of things.
Yeah, definitely. And the monitor is not in front of me. I don't know what's happening to the blood pressure. وبس تحطها في السكرين. Good luck when you see. Yeah.
Exactly. Dr. Yasser, I think here is the hand again. You can unmute.
Yeah, تفضل دكتور ياسر.
Just another question. So I'm used to different systems. So during the handover, so it's gonna take 5 to 10 minutes max. But during that time, who's responsible for the patient care?
Okay, this is great. Some of the slides I mentioned here from hemodynamics, some are suggesting that anesthesia, one of the anesthetists should be there. But I think if you're talking medically, one of the helping assistant intensivist, or if not, the patient hemodynamics, if it's stable, the bedside nurse will leave the patient or will just step aside, and a charge nurse will help her or a nurse colleague will help her. Respiratory therapist, they can listen because the vent is already set and connected. From intensive care standpoint, that's a tricky point, because if the patient needs an active intervention, I would not start handover until the patient is stable. If not, that's a different story. If the patient is stable, then no orders from us will be given at that time. But the same ICU team is there. The patient is under anesthesia until handover is done. You know, I consider that the patient is ours when the handover is, they handed over the patient to me. Until then, the responsibility or the care, I mean, we're there to help, but anesthesia should still be there and manage with us.
Yeah, I totally agree. And I think all of us are trying to be very diplomatic of this and implement it in a team way and getting the stakeholders.
Yeah.
And in where places it doesn't work, I think it just has to be initially forced. In our culture, I think that this must happen. Just as you mentioned, you have to do it, and there's no question, and you just get the evidence is there. It's not like something to argue about. Like it's
exactly.
there. It's gonna happen. We're not going to accept anymore that they'll bring the patient and say he's been stable and leave, or don't give me. Like I would like to know that the rhythm is sinus, even if you. I'd like you to mention that it was normal. The CVP was okay.
100%. I feel you and I agree with you. 100%. Tell me that it's normal. Yes, yeah. I agree with you.
Don't have just to mention what was abnormal. And I can ask my question further, because I think as well, I agree that the patient should be under anesthesia till they finish endorsement to us. And then we take over, because the patient comes unstable or unsedated or whatever. They have the drug we did not receive the patient yet.
Yeah.
Thanks so much. I really again thank you for this presentation to be given again, and I really appreciate that.
No, but thank you for asking for it. I appreciate it, Dr. And we'll work together inshallah.
We learned a lot صراحة. أنا تعلمت كثير اليوم. شكرا.
الله يكرمك.
Appreciate. I think if there is no further question, we can conclude here. Dr. Hussam, it's such amazing talk, which is I feel. And I wish the quality project will be start to shine soon than later regarding the handoff process from the OR as well as the ICU. Thank you so much. It's amazing, amazing talk. This talk will going to be saved and shared as well as in our ICU meeting and through the YouTube channel. Thank you so much.
Thank you for having me. It was a pleasure.
Thank you. Appreciate it.